Hello everyone. So today's topic, what we are discussing is about apexogenesis and apexification. So we will begin with the topic. So we need to understand about what is the difference between apexogenesis and apexification. So one by one we will see about them. Apexogenesis is a treatment designed to preserve the vital pulp tissue in the apical part of the root canal so that the formation of the root apex may be completed. So deep pulpotomy cases to preserve the formative capacity of the radicular pulp is done in an immature tooth that have deep pulpal inflammation. What are the examples for this apexogenesis procedures? Example, caries exposure and some trauma cases in which a treatment of the exposed pulp is delayed and is necessary to extend the further into the canal to reach the healthy tissue. So apexogenesis is actually a physiologic procedure. Formation of the apex occurs in vital young permanent tooth with appropriate vital pulp therapy. If the normal pulp tissue with minimal inflammation is present, normal root end development ensues or can be expected. However, in immature teeth with the pulp necrosis and bacterial infection, long-term prognosis is related to the stage of the root development and the amount of dentin present at the time of injury. What is the rationale behind this procedure? Poor long-term prognosis of endodontically treated teeth with immature teeth leads to relatively thin dentin in obturated canal in incompletely formed roots, and open apices are at risk of fracture. So pulp revascularization and repair will more readily occur in the teeth with a wide apical foramen. Pulp of immature teeth has a significant repair potential. So these are the rationale behind apexogenesis procedure. What are the indications where this procedure is proposed? First one is the traumatic luxation, fractured tooth with pulpal exposure and caries exposure. What are the goals behind this procedure? Goals include sustaining a viable Hartwig sheath to allow continued development of the root length for a favorable crown root ratio. Treatment strategies of traumatized immature permanent teeth should be aimed at preserving the vitality of the pulp to secure further root development and tooth maturation. Then promoting a root enclosure and generating a dentinal bridge at the site of pulpotomy. So after considering the goals, what are the contraindications of this procedure? There are some situations where even though this procedure cannot be done, the contraindication include severe crown root fracture that requires intraradicular retention for the restoration, teeth with unfavorable horizontal fractures that is close to the gingival margin, then caries teeth that are unrestorable, and necrotic pulp. So here you can see in the photographs. So here is a fracture site showing where the fracture site is very near to the gingival margin. So teeth with so much loss of root structure, we cannot ensure that the normal healthy pulp can be maintained. So we need to do root canal and then advise root and procedure to improve the crown root ratio. So such situation you cannot advise apexogenesis procedure. Here also another case where a lot of root structure has been lost. So rather than going for apexogenesis, we need to think of something else. So what are the procedures where means a procedure to carry out the apexogenesis? Any deep resection of the pulp tissue is usually undertaken in a single anterior teeth with a small amniotic spool excavator, a round and abrasive diamond bore. In posterior teeth, the use of amniotic files or the reamers can be used if necessary to amputate the tissue within the canals. Extension of the amputation site into the root canal is undertaken only when there is a little confidence that more superficial pulp capping or pulpotomy will be successful when there is a desperate desire to preserve the pulp functions in the teeth with wide open blunderbuss apices. After removal of the excavate or cutting of the or removal of the pulp tissue. Bleeding is controlled with coronal pulpation. Bleeding is controlled with the saline soaked cotton pellets or use of sodium hypochlorite irrigant. If homeostasis cannot be secured or achieved by conventional means, this may indicate that even a deep tissue is deeper layer, the inflammation has reached the deeper part of the pulp tissue and the treatment will be compromised. Despite the risk, it is a legitimate to attempt pulp preserving procedures after controlling the hemorrhage with hemostatic chemicals such as alum chloride or ferric sulfate. The pulp wound is then covered with the dressing material before the crown is securely restored. It is challenging to determine the status of the pulp tissue deep in the root canal and its capacity to survive is difficult to predict. Then after that, radiographic and clinical follow-up is mandatory. And if there is no evidence of continued root formation and calcific barrier formation in a response to the dressing, apexification or regeneration technique might be considered. If apexogenesis is successful and the root end formation is complete, the tooth could be re-entered if desired for conventional root canal treatment. Materials used for apexogenesis are usually calcium hydroxide and MDA. Calcium hydroxide powder has usually been preferred over hard-setting products carried into the canal with an amalgam liner or a gun system for MD application. Small increments of calcium hydroxide powder are carefully teased against the entire surface of the pulp stem with a round-ended plastic instrument, ideally with a microscope control. Care must be taken not to pack the calcium hydroxide into the pulp tissue because this causes greater inflammation and increases the chances of failure. So always place the material with the light hands. Even the pulpectomy is successful, there is an increased risk that the remaining pulp tissue will mineralize around the impacted particles of the calcium. Commercial non-setting calcium hydroxide paste may also be spun or injected into the injected to flow lightly over the pulp stem. Care must be taken to avoid trapping of air bubbles with such products applied, and is recommended that they be overlaid with a hard-setting calcium hydroxide or a glass polymer cement before meticulous cleaning of the cavity walls, and the restoration with a bonded composite resin restorative. Because the depth at which this procedure is performed, preference has usually been given to the use of calcium hydroxide rather than MTA, because in the event of failure, this may facilitate re-entry of the canal to perform apexification or even pulp regenerative procedures. If apexogenesis is successful and root end formation is complete, the tooth could be re-entered if desired for conventional root canal treatment. So this is a schematic representation of apexogenesis. Here we can see that diagram A, where you can see an open apex, where wide open apex with blunderbuss canals, and the thickness of the dentin around the root is also very thin. So here what they have done after removal of the coronal pulp tissue, wound dressing is given by using appropriate pulp material. Then coronal restoration has been sealed. After continuous successful after follow, we can see the formation of root end is completed, and along with that, the adjacent thickness of the root dentin is also improved, and crown root ratio has considerably uh, improved compared to the previous one. So this is an example where radiographic evidence where around 18 months recall and follow-up has been done for the patient. Here we can see a fractured tooth with an open apex, and we can see the blunderbuss canal is also there, and there is no closure of the apex visible. So calcium hydroxide pulpectomy was done in the patient, and after 3 months recall, we can see a calcific barrier has been formed where the calcium hydroxide dressing was given, and we can see slightly tapering of the apex of the root canal, and we can see the dentin around the tapered form of the root is also improved, and at the end of 18-month recall you can see completely formed apex and improved root dentin thickness, and evident calcific barrier is seen at the junction of the vital pulp tissue. So this is good case where apexogenesis was considered was fully successful. And then going on to the next part of the chapter, that is apexification. Apexification or the root end closure is a process in which a non-vital immature permanent tooth that has lost the capacity to further root development is used to form a calcific barrier at the root terminus. So this barrier forms a matrix appendage to which you can root canal filling or a restorative material can be compacted along the length of the root canal in a controlled manner. So why apexification instead of conventional RCT? So, for the convention, because the apex will all be open in these cases, the canal will be blunderbuss, thin and fragile canal walls, and absolute dryness of the canal is difficult to achieve, which is a must for the observation, completion of the root canal procedure. And then, what are the indications for apexification procedure? Young permanent teeth with non-vital or necrotic. So this is a radiographic representation or a example of blunderbuss canals where this apexification procedure where the tooth has become non-vital. So here is an anterior tooth which has exposed to pulp and you can see flat periapical lesion. So it dictates the tooth is non-vital in nature and cannot progress further. This premolar also shows us a traumatic injury of the periapical region with a periapical widening and obliterated lamina dura and a blunderbuss canal. So these are the examples for selection of apexification cases. What is the objective behind this procedure? Induce a root end closure to form a complete calcific barrier at the apex with no apparent pathosis. But what are the contraindications? Very short roots, marginal pedontal breakdown, and vital pulps. Material used for these apexification procedure, again calcium hydroxide, most sought out material, then collagen, calcium phosphate gel, then mineral trioxide aggregate, and osteogenic protein 1. Use of calcium hydroxide as a apexification or rooted filling material are first one, presence of very high alkaline pH around 12, bactericidal properties, and it is ability to stimulate the apical calcification. Reaction of the periapical tissues to calcium hydroxide is similar to that of the pulp tissue. The calcium hydroxide produces a multi-layered sterile necrosis, permitting the subsequent mineralization of the tissue surrounding the calcium hydroxide. But even though it has many advantages, there are few serious advantages of calcium hydroxide, which includes the treatment is long-term in nature. So you cannot achieve the treatment within 1 or 2 settings. The patient has to visit the doctor for around 6 to 9 months to even to see any visible differences from the radiograph. And the treatment might even extend up to 21 months. And the calcium hydroxide has to be changed at the monthly interval and removed some months after the placement before the final obturation. Because of that, because of this, the patient has to visit the dentist many times. Because of the multiple visits, again the chances of recontamination is also increased, and calcium hydroxide is has been cause weakening of the root dentin and risk of teeth fracture. So, because of these serious disadvantages of calcium hydroxide, MTA material has become a material of choice because it saves a lot of time in the treatment and can induce formation of dentin, cementum, bone, and even periodontal ligament. It has excellent biocompatibility and appropriate mechanical properties required for the procedure, excellent sealing properties, and produces an artificial barrier against which an obturating material can be convinced easily. It hardens or sets in presence of moisture, so there is no need of worrying about any blunderbuss canal or a canal where absolute dryness cannot be achieved. More radiographically, it is more radiopaque compared to calcium hydroxide. So follow-up is very easy, and you can easily understand where the material is being placed, and it is also constructive in nature. So, what is the technique of placing MTA as apexification procedure? First, anesthetize the tooth and isolate with a rubber band. Gain straight line access to the canal orifice. Extirpate the pulp tissue remnants from the canal and irrigate with sodium chloride. or saline also. Establish the working length of the canal. Place the appropriate material for apexification procedure in the canal, that is calcium hydroxide, to initially because the antibacterial property of the calcium hydroxide before directly placing MTA, one or two appointments calcium hydroxide has been can be given. Then effective temporary seal between the visits, so fortified zinc oxide, usual cement or iron is preferred to be placed over the coronal part of the tooth. Then, a second visit, the patient is required after 3 months. If any symptoms, if symptomatic, the canal is again clean and again filled with the calcium hydroxide, then the patient is again recalled and examined for the radiographic evidence for the information. If the evidence is confirmed using the radiograph, you can confirm with the clinically by passing an instrument and check for any barrier for passing of the instrument. The apex after removal of calcium hydroxide, repeat the process if no satisfactory results are found. Treatment time usually takes around 6 weeks to 18 months for the calcium hydroxide. So how do you confirm the evidence of root apical closure? Frank has described certain four successful points where you can confirm the root end formation or root end apical closure. First, continued closure of the canal and apex to a normal appearance. A dome-shaped apical closure with the canal retaining blood vessels appearance with no apparent radiographic change but a positive stop in the apical area and a positive stop and radiographic evidence of that, or finally coronal, which is coronal to the anatomic apex of the. Final obturation is done only if there are absence of any symptoms, absence of any fistula or sinus, absence or decrease in the mobility of the tooth, evidence of firm stop clinically as well as radiographically. So this is a radiographic demonstration of a case which was chosen for calcium hydroxide apexification. So you can see in the first picture, the tooth has become normative with little widening. Apical pedontitis is visible and necrosis has been seen. So working after access preparation, the canal working length is confirmed. Cleaning and shaping is done to remove the necrotic tooth tissue, and calcium hydroxide dressing has been placed. And the tooth is tempered with the interim restorative material. Again, the patient was required after 6 months, and another radiograph was taken using file, and the file after confirmation of a positive barrier using a clinically checking the barrier using a file, which was confirmed using taking a radiograph, and you can see a dome-shaped radiographic appearance at the apex. So then again the patient has again recalled, and furthermore again once more dressing was given, finally to then recalled at 11 months of upon 11 months of your procedure time, the treatment procedures, and then obturation was achieved using various obturating material, and further the tooth has been given a post to improve the crown root ratio, and a crown is adjusted. So this is a procedure for apexification using calcium hydroxide. So one visit apexification is also carried out, which where calcium hydroxide is not used, rather than MTA used. Disadvantage of conversion technique using calcium hydroxide includes poor patient compliance because many times patients fail to return for the scheduled visits, which might lead to further failure of the treatment. The temporary seal which is given during inter-appointment timings may fail to seal the coronal section of the tooth structure, and the chances of reinfection and prolonged reinfection and also even prolongation of the treatment will occur, or sometimes even failure of the treatment can be expected. So the rationale is to establish an apical stop that would enable a root canal filling material immediately. So no attempt to root end closure can be done. So rather than an artificial apical stop, rather than achieving a natural root end closure procedure, an artificial apical barrier is created and using material, and this material is MTA, and the usage of this procedure is said to be one visit apexification. So here is a schematic representation of immature tooth where the pulp has become necrotic. Then uh, cleaning shaping, working and cleaning shaping is achieved. Then a calcific barrier, but porous calcific barrier is achieved after placement of the calcium hydroxide in between the treatment. Then a composite restorative metal is given. Then after that, this is first one is using the calcium hydroxide, and the second technique is apical barrier technique using MTA, where MTA is directly placed at the apex to achieve a artificial apical barrier, and root and restoration is continued based on the requirement of the tooth. Tooth restoration following apexification. High incidence of root fractures are more common in teeth with apexification. So, because the dentinal walls are usually thin compared to apexogenesis cases, so restorative effort should be directed towards strengthening the image root. So, teeth to be used as an overdenture abutments to be avoided. So, this was about the difference between apexogenesis and apexification. I hope you understood the topic, or whatever the doubts you had in your mind might have been cleared.